Begin the assessment by inspecting the chest front to back, noting thoracic landmarks, size, shape, color, and symmetry. Observe for prominence of ribs and deformities. Evaluate respirations for rate, rhythm, pattern. Inspect chest for pattern, symmetry, and use of accessory muscles. Upon respiration, noting audible sounds. You'll perform this respiration check for 30 seconds and multiply times 2. Next, we'll move on to observe the patient's mouth, noting their lips and mucosa for color and pursing of the lips. Also examine the nails for cyanosis and clubbing. Also noting if there's any nasal flaring. Next, we'll palpate the chest for symmetry and thoracic expansion by placing the thumbs on the patient's back at the level of the 10th rib, watching for the thumb to diverge during quiet and deep breathing. Next, we'll palpate the vibration of the chest wall for tactile fremitus. Fremitus is felt by first placing the palmar surface of both hands on the patient's back at the second intercostal space at the level of the bifurcation of the bronchial during speech. This can also be evaluated by using the ulnar aspect of both hands positioned in the same location, having the patient speak by reciting numbers or saying words. If the trachea has not been assessed previously, then examine it at this time. Next, have the patient bend forward with hands folded in front. Begin percussing the intercostal spaces, moving systematically, either superior to inferior or medially to laterally. For resonance, which is the norm, and any signs of hyperresonance, dullness, or tympany. Percussing directly and indirectly the posterior thorax and left lateral thorax, anterior thorax, and then moving right lateral thorax, having the patient raise hands above the head to assess right and left lateral thorax. Next, move. You'll also do this by direct and indirect percussion in the same systematic formula around the patient. The next part of the exam will move on to diaphragmatic excursion by asking the patient to take a deep breath and hold it. During this assessment, you will percuss along the scapular line, locating the lower borders from resonance to dullness. When you find this area, you will mark it with tape. Next, have the patient take several breaths and exhale and hold it. Percuss up from the marked point and mark at the change from the dullness to resonance, reminding the patient to breathe in between. You'll repeat this on both sides, and then you will measure with a ruler. The distance in between the tape should be 3 to 6 centimeters. The next part of the examination will begin by auscultating the patient by having them breathe slowly and deeply through the mouth. Auscultate the back with the patient sitting, bending forward with arms folded for auscultating anterior chest. Have the patient sit upright and raise arms for lateral chest. Sounds on each side. Listen systematically at each location throughout inspiration and expiration. In a side-to-side comparison, moving downward from apex to base, assessing bronchial area over trachea, vesicular area over lesser bronchioles and lobes, including bronchial vesicular area over the main bronchi. Next, we'll assess for vocal resonance through auscultating the spoken voice through the lung fields with the stethoscope. This is best heard medially. Have the patient repeat spoken words as assessment progresses.